Before we get into the presentation, we had some questions about ICD-10.
Oh, there he is. What? Oh, yeah. He's not paying attention. Let's surprise him. He's typing. Hey, you. I'm teasing. You want to ask Dr. Sharp
The same one about the muscle spasm? Yeah, we were talking about the unspecificity being the death knell of your codes, and we covered it a little bit already, but when you get down into some of them, there's not that level of specificity. There's not T5 rib subluxation, there's just rib misalignment or whatever the words are for it. And same thing with muscle spasm. It's hard to get very specific into what muscle is in spasm. So I guess the question is it okay to use an unspecified code and then indicate in your notes right trap spasm, left splenius capita spasm? Would that be the same thing as using a code that's more specific?
Right. There really is no specific ICD-10 code per muscle. So right now there's actually a very non-specific muscle spasms called back muscle spasms code. I wish I could remember it off the top of my head, but that's all you have to do. So either strain diagnoses for the cervical, thoracic, lumbar, and pelvis that are about as specific as you can. But with respect to back spasms, it's just a back spasm diagnosis. It encompasses everything. Okay?
Kevin said.
Kevin said, yeah. Well, I'm good at repeating what CMS said, okay? You do want to get as specific as you possibly can with your codes. You know, when Parker was talking about some of the changes with CMS and tiering doctors, I hope you heard that. I hope you were a little trepidatious about that, because I'm here to tell you, and if you sat in any of my ICD-10 seminars, it's the shot over the bow. You have got to learn how to use these codes well. Getting your claims paid right now is not necessarily meaning you're coding well, okay? So you've got to continue to do that. I was on the phone yesterday with the ACA. We're starting to do the ICD-10 2 seminars, which will roll out. I think I'm going to do a series of webinars for the ACA about more documentation specific and coding specific things. If you're not getting your codes and looking into an ICD-10 coding book, and you're just getting them from gemming them over or getting a cheat sheet only, then you are definitely not coding to the highest level. So there's more things to learn. You know, no panic, but you need to continue to look at opportunities to learn more about ICD-10 and documentation for that. And then CMS is rolling out an initiative, well, a demand. It's not an initiative, it's a demand for the chiropractic profession to increase the levels of documentation. Again, we're doing that here in North Carolina. H&S is doing that. We're all attending these seminars, and that's, again, we are so much better than most states that I have been to for sure. And boy, you go to the bigger states. I've been down in Texas 3 times. I'm going to go out again in a couple months. And one of the biggest chiropractic states in the country, and it's abysmal how they document and their understanding of coding. So not that we should rest on our laurels, we definitely want to pick it up, because we won't be necessarily put up against folks in Texas. We'll be compared with what's going on here by our own MAC. So we want to be up on top of that. So you've heard it now, and that's good. One little thing I did want to mention, and we haven't even discussed this yet, about the 7th character. How many of you are using the 7th character? Okay? How many of you don't know what the heck I'm talking about? Okay? Me. All right. So the 7th character are usually used with what kind of codes? S codes or injury codes, right? Those injury codes. A is for active treatment, D is more for rehabilitative treatment, and then S is for sequela. So we talked a lot about active and sequela, and so lately we've been hearing a little bit more explanation of when you should be using a D 7th character. So this is how I will describe it. The only time you're using a D 7th character It doesn't necessarily have to be during maintenance care. It can be applied when the injury code is a secondary, or tertiary diagnosis, and so there's a primary diagnosis. So while the injury code may not be as big a factor in your care plan, but other diagnoses supersede that. So it could be a secondary, tertiary. So while you're still treating the patient actively for those primary diagnoses, those secondary, tertiary diagnoses are in the rehabilitative stage. So, crap, I knew she was going to do that. So let's say, yes, I will. I'd be delighted. Yeah. Yeah, I'm confused, but I live in a state of confusion most of the time. No, a good example of that would be like if we had a patient, let's say they're in an injury, they're injured on June 1st. Okay, they're in an auto accident. Things are doing well, the case is resolving, you're coming down, but then they have a new injury or new complaint that supersedes that, okay? So now, even though those primary injury codes are resolving or resolved, for the most part, not resolved, resolving, the primary codes, the new injury would supersede that, and so while you're still working on that injury code and working on those new primary codes, that's when you would use the D code. Does that make sense? To a degree? No, it doesn't make sense. Okay. So let me be more specific. So again, you're in an automobile accident on June 1st. On July 1st, okay, you are out working in the yard and you have a neck injury, okay? Whereas in the auto accident, you had a low back injury. At that point, the injury code, the initial injury, is you're finishing up that course of care for that diagnosis. But now you have to deal with the neck injury. So that would be your primary diagnosis. So as you're going through the care and you resolve the injury, which would be the low back, then you could put a D on as the seventh character as you continue to finish out the course of care with that. So you're still adjusting the neck and low back, and you're designating that as being under rehabilitative care. Okay? You probably will not be doing this often because that's not a likely scenario, but that's how it was explained to me. And that actually was a case scenario from CMS.
Am I right, though, that, so let's say now your primary is M99 something,
Yes.
and your second is S injury code, and you're saying a D.
Mm-hmm.
But if, in fact, you forget this, you know, you've forgotten about today, and you put an A indicating, for lack of a better word, active care,
Mm-hmm.
Are you anticipating that at some point that would create a problem for the payers? How would the payer know if there is a new injury? I'm sorry, if there's a new problem and so we have an M99 as a primary, but you're still treating the injury.
Sure.
And if someone hadn't heard you say this, and right now that's not what's in our crash course.
Right.
You know, which of course we can change. But I guess what I'm thinking is, how would Blue Cross know? I mean, is there really any harm in having the A as the seventh character in that case?
I don't think so.
Okay.
Just for practicality, I'll probably, well, two things I would say. Probably fine to leave the active seventh character on there.
In your crash course, and for those of you that have seen Dr. Fusinari's seminar, and as Kevin will attest, 2 months ago what we were told by CMS and ACA and everybody was, for the seventh character, if you have an injury code, you must have a seventh character. A is when the patient is in active care. D was only to be used when the patient was no longer in active care, i.e. you have switched them to maintenance or supportive. Well, as a general rule, you can't bill maintenance or supportive, right? So sort of what I've told our doctors is, now there are a few plans that cover maintenance, so there's a couple of exceptions, but as a general rule, every time you're using an injury code, you would use A. And as soon as you switch them to active or maintenance, you just quit billing because you're not supposed to bill that. This is why I'm trying to get some clarification because I think this may be, it's very good information, but it may be a little hard to explain in writing when I update the crash course, you know, in a way that doctors can understand. That's why I was asking if I don't see the payers, if it did come in with an, I'm not disputing, I'm sure your information is right, but I'm thinking if it's still, the injury code still had an A, they've not done anything faulty, the payers aren't going to be upset by it or stop payment on it.
Sure, sure. And I think I wouldn't run out and start putting D seventh characters tomorrow. I won't in my practice. But this is literally, this was part of my call yesterday with the ACA, is coming out and they're asking for further determination. The problem is you're getting conflicting information all over the place. So the other thing I would say, to step back to the scenario I just said, and she was giving some codes, you want to make sure that if you were using the D or the S code, or the S7th character, excuse me, those are going to be lower in the hierarchy of codes. So all the other codes are going to be at the top. You know, the sequela codes, any other new injury codes or anything like that are going to be at the top. So again, this is part of ICD-10. Where you place those codes becomes very, very important now. They've always been important, now they're more vital. But I think with respect to your suggestion as we continue to use the A or the S code when appropriate, you're going to probably use the A code 90 to 95% of the time. You may use the D code once in a while and the S code a little bit more. But you know, stick with it. Again, most of the time you'll resolve the injury, you'll take that code off, you won't use that code after that's resolved anyways. But it is changing. There'll be some other things that will change, and that will be on a state-by-state basis. The other thing that came out is the subluxation complex codes versus the subluxation injury codes. At this point, still do not use those codes, but that is being discussed at a higher level, and that may change. My point being that ICD-10 is very fluid at this point, and you may be getting your claims paid at this point, but that may not mean that that's proper coding 3 months from now, okay? And all that stuff will come in North Carolina. We're fortunate we'll get all that stuff through H&S. So Mario and I and whoever else you talk to will have that. There was a question over here. Yes? Yeah, well, that's a good point. Well, you know, again, there's different answers for different. Well, it would be inappropriate to bill the auto carrier for an injury that happened while raking in the yard too. So again, we could probably spend a lot of time talking about various scenarios. Heavens, if, you know, in this case, if the patient was a Blue Cross Blue Shield patient and was an auto case in my office, I'm going to bill the Blue Cross Blue Shield for him anyways. And then it's no big deal. Then I just, you know, this is a great case scenario. I mean, I know it's great to make more money in personal injury and through liability and med pay, but this is a case scenario that it works very easily when you're dealing with group health, because you can change onset dates, you can change diagnoses, you do all your notes, your outcome assessments. My informed consent, of course, I would do that on that day, and then it makes it a little bit more streamlined. So, okay? All right, we got so much information, and if you have ICD-10 questions, by all means, don't ask me, okay? No. I'll be happy to answer those questions at the break, and I will be teaching an ICD-10 class at the fall convention, the NCCA fall convention out in Pinehurst. So that'll be a great, that'll be on Sunday morning from 8 to 12. That's exactly what I want to be doing on Sunday morning. And And then I'll be doing a CA program out there as well. So that's on Saturday. Okay, and playing a little golf on Friday. So a little golf, a little CA work, a little ICD-10, a perfect weekend. All right, so what does medical necessity mean? So let's talk about medical necessity, and this is what the North Carolina Department of Insurance defines it as, okay? It means those covered services or supplies that are provided for the diagnosis, treatment, cure, or relief of a health condition, illness, injury, or disease, and except as allowed under the statute, but not for experimental, investigational, or cosmetic purposes. Number 2, necessary for and appropriate to the diagnosis, treatment, treatment, cure, or relief of health condition, illness, injury, disease, or its symptoms. And number 3, within generally accepted standards of medical care in the community and not solely for the convenience of the insured, the insured's family or provider. Number 3, wouldn't that be kind of maintenance care, right? That kind of refers to us. For medically necessary services, nothing precludes an insurer from comparing the cost effectiveness of alternative services or supplies when determining which of the supplies or services will be covered. So this is what I dislike most, is when a patient comes into my office. We do an exceptional job educating them, taking them through the course of care. Then we come to that point where we make that change, convert them to non-covered services. We've only treated them for 15 visits, and they still have 15 more visits under their policy, right? So most of the time, we've walked them through that process. It's not a problem. But some of the times what happens is they'll say, well, listen, I've got 10 more, 15 more visits, and then we want to move on. We want those maintenance visits covered under that 15-visit plan. I've called Blue Cross Blue Shield. They've said what they've said. So you go back to medical necessity, and this is where you need to live at as you explain this, and we'll talk a little bit more about that later. But what I don't want to see is then my patient go down to the street to one of my colleagues and then is put on maintenance care. And they bill it. Okay? Because that undermines the whole process. It undermines me, and I'm following the rules. It underlines the contract, underlines the profession. And then, of course, as soon as that patient has used all their visits, they're going to leave you anyways, right? So it's better to be honest and forthright. And I've seen that from time to time. But make sure your staff understands this. This is really important. And staff, if you do not have a good handle on this, I'll be happy to talk to you at the breaks. And we'll spend some time at the end of this because it's more important. So as a general rule, insurance plans only cover medically necessary chiropractic care as designed in the corporate medical policy, the CMT, or CMP. Not all clinically appropriate care meets the payer requirements for medically necessary care. So you need to understand that as well. As physicians representing certain health care plans, we are required to know and comply with the CMP, including how they define medically necessary care. And these CMPs are posted on the H&S website in the H&S Payer Policy section. How many of you have ever read those corporate medical policies on the website? Okay, 4 of us, okay? Again, this is not, exciting reading, but it's good reading. You do it once in a while. The other thing is looking at the fee schedules as well. All that information is listed on there, and it's very enlightening to get that. So, again, they've done a great job of providing that for you, so I would encourage you to look that up. So let's look specifically at Blue Cross Blue Shield and their corporate medical policy. It in part states chiropractic services are considered medically necessary when all the following criteria are met. The patient has clinical symptoms of a condition that may be improved or resolved by standard chiropractic therapy. A clear and appropriate treatment plan is documented, including symptoms, diagnosis, being treated, diagnostic procedures and treatment modalities used, results of diagnostic procedures, treatments, anticipated lengths of treatment, and quantifiable, attainable treatment goals. Isn't this what we talked about all morning? So the corporate medical policy is take this sentence, this little paragraph, that's what you need to live by. As long as it adheres with that, then you can bill for those services. If it doesn't, it doesn't. The diagnostic procedures, treatments are clearly related to the patient's symptoms and condition, and manipulation of modalities must be consistent with the patient's chief complaint, clinical exam findings, diagnoses, and treatment plan. Okay? It also states in part that when chiropractic services are not covered, chiropractic services are not covered in the following circumstances. When they've gone beyond their benefit limit, services that are excluded from the benefit plan as well. Vertebral axial traction or decompression, including computerized decompression devices designed to provide mechanical traction. It's a non-covered service in North Carolina. Electrodiagnostic, EMG, and nerve conduction, unless rendered by a certified chiropractic neurologist. Kinesiotaping is a non-covered service. Therapeutic manipulation modalities that are not clearly related to symptoms and/or diagnostic x-rays, or that are not likely to result in long-term improvement of a member's symptoms or conditions. So again, even though, my patients love to be on that intersegmental traction table. I'm thinking about stopping to charge for it and just putting a little quarter slot in there, so they have to put quarters in there. I'd probably see 5 patients a day, right? They'd sit there with a roll of quarters. But sometimes they don't need it, okay? Sometimes they want it. There's a difference between want and medically necessary or need. So you've got to make those decisions. And the following therapeutic modalities: counseling considered integral to the visit, low-level laser cold therapy. Let me go back to A. So again, you realize that your 989 codes include a portion of an E&M. There's an E&M component to that code. So even though you have to stop, explain something to a patient, that doesn't automatically mean you need to bill a 99 code for those patients, because that 989 code includes a portion of that E&M experience. A low-level laser, great therapy, right? How many of you are using laser in your practice? Okay. Great therapy, but it's a non-covered service, okay? Again, another cash service. Covered 100% by MasterCard, Visa, American Express, Discover card. 100%. No limitations. Most of the time, okay? It also, again, things that are not covered: maintenance programs or supportive care, and to comply with H&S and payer CMPs, and to ensure the provider is accurately and timely determining when MMI has been reached, we must have a clear understanding of what supportive care is, okay? So that is very important, okay? So again, let's kind of go back before I go into supportive care. Again, understanding the corporate medical policy. I mean, at the end of it all, again, I like rules. I like to know what I can do, what I can't do, what I've got to do to stay within the box, stay out of trouble. So these corporate medical policies give us that. This presentation gives us that latitude, gives you that understanding. So it's a matter of just staying within that policy, and you shouldn't have any problems. Now, I say that, and we continue to have doctors that push out of that policy all the time, okay? I think of Medicare, all right? We've got like a 35% clean claim rate to Medicare, and we only have 3 codes, okay? Imagine if we had 100 codes in Medicare, it'd be probably less than that. So it's not very difficult to stay in compliance with Medicare. It's pretty easy to stay in compliance here with Blue Cross Blue Shield and their corporate medical policy too. Nothing's very gray, it's very specific, okay? Any questions on corporate medical policy? Okay, supportive care. My favorite kind of care. I was talking with Dr. Chris back here earlier, and on Thursday, my last day in the office, we're just going through patients, and at the end of the day, I went back and counted the number of cash patients that I saw on Thursday, and it was exactly to the one. 50% of my patients were cash on that day. So most of them were supportive care or maintenance care patients. Some of them were just cash patients. But by and large, those are supportive care patients. I love supportive care patients. Easy to document, they're compliant, they don't, there's no hassle paying for their care, they're very good about paying for their care, and most importantly, they're well. They're engaged in chiropractic, they understand the health and wellness of chiropractic, so at the end of the day, we want to push people into this. But there's a method to do that. So let's talk about supportive care a little bit. Supportive care is treatment care or care for patients who have reached maximal medical benefit but who fail to sustain benefit and progressively deteriorate when there are periodic trials of treatment withdrawal. Supportive care follows appropriate application of active and passive care, including rehabilitation and/or lifestyle modifications. So supportive care is appropriate when alternative care options, including home-based care or referral, if that's necessary, have been considered and/or attempted. And supportive care may be inappropriate when it interferes with other appropriate primary care or when risk of supportive care outweighs its benefits, i.e. physician, treatment dependence, somatization, illness, behavior, or secondary gain. Again, it needs to be, there needs to be a method to it. That's the other thing that I would say with supportive care. Some of you kind of let your patients dictate their supportive care. And I think there's some differences in there. Certainly have patients that come in from time to time, but I have patients that would come in once to twice a week to get adjusted. And they don't need to be adjusted once or twice a week, right? Yes?
I would just like to add one thing that happened this week. I was doing a records review for one of our contracted partners, and included in the record was a copy of this sheet right here, which gave the definition from the ACA on supportive care. And it was pertinent to that case because that was the question. But they have this data and they use the same data, so we need to be aware that they are aware, that the payers are aware of this situation. They know what definitions we need to be living by.
Right.
Right. Holding us to those standards.
Yeah, so when we finish our documentation manual at the ACA, who's going to buy that? Well, Parker's going to buy one, right? I'll buy one to give to my mother, right? Okay. No. And Blue Cross Blue Shield will have that. CMS will have that. All the payers will have that book because that's the standard of documentation. So, but stuff like this will be in that. That's a great idea to have that document in your notes, if you could use the verbiage out of that and reference the ACA in your notes as well. Supportive care is treatment or care for patients who have reached maximum therapeutic benefit but who fail to sustain benefit and progressively deteriorate. Supportive care is not covered by insurance, okay? Not covered by insurance. I know I'm going through this stuff quick. I really want to get to some notes here before the end of the day, so if there are any questions, if I'm not covering something in enough detail, please let me know. Let's talk about maximal medical improvement, okay? So maximal medical improvement occurs when a patient with an illness or injury reaches a state where additional, objective, measurable improvement cannot reasonably be expected from additional treatment, and or when a treatment plateau in a person's healing process is reached. So let me talk about that for just a moment, because it's very easy when we're MMI and they're asymptomatic, right? We'd love all of our patients to be asymptomatic. But what is more difficult is when the patient is only 50% improved, but that's the best it's going to get, right? So you get those chronically injured, chronic musculoskeletal, neuromusculoskeletal, those patients with peripheral neuropathies that you're trying to work with. And of course, intellectually, if you would say to them, if I could improve your symptoms by 50%, would you be happy? And they all would say, yes, absolutely. But when you're in the middle of care, they want to become asymptomatic, just like you want them to become asymptomatic. So that's not necessarily the goal. It may be the goal, but it may not be the outcome. So just understanding maximal medical improvement may be their plateau or getting them to the point that they have benefited from chiropractic care to its limit, okay? In its simplest form, maximal medical improvement, MMI, means that additional treatment is not likely to produce additional functional improvement. This is not to say that the patient may not regress in the absence of further care, but if so, treatment would be supportive care, which is not covered by insurance. A comparison of the results from the outcome assessments, the OAs, are done at the initial exam, progress exams, and then at the end, in essentially all subsequent exams, in determining whether the patient has reached MMI. So remember back to that outcome assessment that I showed you and we had graphed. It kind of came to a point. Once we exceeded that treatment, what happened? It went down. At that point, she was definitely MMI. She should have been considered MMI on that last progress exam. But you'll find those examples in your office. If they come up here and then they stay a consistent line on those outcome assessment forms, at some point you need to release them to supportive care and keep them MMI. So again, a lot of those patients need ongoing chiropractic care for the rest of their life. It's just not happen to be covered under their insurance policy. What policy are they covered under? MasterCard, Visa, American Express, Discover, right? Okay, very good. And if you have not initially established reasonable, objective, and measurable treatment goals, then you just can't evaluate the treatment effectiveness nor determine when MMI has been reached as well. Okay? And if you aren't measuring patient progress towards treatment goals and effectiveness of treatment using the outcome assessments, you're just not going to be able to objectively determine when MMI has approved. Okay? Now, this is from the Board of Examiners, so this is your licensing board. If a patient fails to show initial improvement after 2 treatment cycles, the physician should assume that maximal medical therapeutic benefit has been achieved and the patient should be switched to maintenance or supportive care, referred or released from care. Okay? If a patient who initially showed improvement subsequently fails to show further improvement after approximately 4 weeks of care, the physician should assume that maximal therapeutic benefit has been achieved at that point, and the patient should be switched then to maintenance or supportive care, referred or released from care completely. Okay? So when the patient has reached MMI, this information should be communicated to him or her. Again, I wouldn't do this on the last visit. This communication, engaging your patients into the process of care, begins on the first visit and throughout the course of care. That's why I said earlier, when you go to that first progress exam, that's a great time to really get the patient focused on where they're at in their care and where they need to go from there. A lot of times, you've heard me say this, but I say it all the time in my practice, when patients are so focused in on pain, so if it's too much pain or too little pain, we address that now that we've got the pain, now that the pain's under control, now let's focus on the healing process of what we're doing. We want them to understand the healing of the joint, the functional improvement of the joint, so then when we get to the end, they're thinking function, not pain. The absence of pain does not mean the absence of disease, right? So this is very chiropractic if you use it in the right way. As soon as MMI has been reached, the patient must be released, referred, or switched from active care to maintenance supportive care. And again, those visits cannot be billed to the payers. Okay? So this is the risk to you with respect to MMI. Failure to clearly and appropriately establish when MMI has been reached will inevitably result in billing for maintenance or supportive care visits. This is the OIG point, right? Audits of healthcare records. The number one reason for payer audits and demands for repayment from chiropractors are due to the inappropriate billing for maintenance and supportive care. Failure to clearly, appropriately establish when MMI has been reached results in billing for maintenance and supportive care visits, which may result in audits by the payers and CMS for that matter, and demands for repayment. So we want to avoid that. So if this is the number one reason that we're being asked for repayments, then this should be really important to you and what you're thinking and doing in your practice. So if you're not doing good discharge notes, when you're finishing up the course of care and moving patients from active care to supportive or maintenance care, that is a high priority for you on Monday in your notes. Okay?